Welcome to Healthcare Upside Down with your host, Dr. Nick Vanterhaden, and brought to you by ECG Management Consultants. You can learn more about the show on the program's page at healthcarenowradio.com or on our blog at ecgmc.com/HUD. The U.S. spends more on healthcare per capita than any other country on the planet. So why don't we have superior outcomes? Why haven't the principles of capitalism prevailed? And why do American consumers have so much trouble accessing and paying for healthcare? Each week, Healthcare Upside Down will dive into these and other issues with ECG principal Dr. Nick and guest panelists as they discuss the upsides and downsides of healthcare in the US and how to make the system work for everyone. And we end with your better pill to swallow, the conclusion to today's episode with insights on challenges and changes that improve healthcare. Now here's your host, Dr. Nick.
There are wide variations in care throughout the world, but as we have seen repeatedly also within the United States. You may have seen headlines that suggest your zip code is more important than your genetic code in determining your health and life expectancy. These data offer a window into the care being delivered and the fundamental inequities and health disparities that are pervasive and amplified by the pandemic. But the differences conceal even more troubling insights that transcend income, discrimination, and racial lines and can be found everywhere. Waste permeates our system, generally estimated to be of the order of 1/3 of $4.1 trillion we spend in the United States. Think about that for a second. If waste accounts for that much, that is the order of $1 trillion. Does it help to explain that $1 trillion is a million? Think what we could do with that money spent on actual healthcare. As Atul Gawande outlined in his New Yorker article, The Cost Conundrum, which focused on the town of McAllen in Texas, which is one of the most expensive districts for healthcare expenditure in the United States. Did this work demonstrate this additional spending results in better outcomes for patients receiving healthcare? Based on the standard metrics of quality of care, it does not. In some of the original work around these discrepancies, the data showed that if you live in a high spending area of healthcare, you receive more medical treatments. How much, you ask? 60% more medical treatments? That was made up of more frequent tests, procedures, more visits with specialists, and more frequent admissions to hospitals. But when measured against matched cohorts of people with similar diseases and health profiles, they did no better than other patients who'd lived in areas with lower medical care being delivered. These measurements held for survival, patients' restoration of function, and satisfaction with the care they'd received. Join me on Healthcare Upside Down show as I talk with Dr. Elliott Fisher. He's the Professor of Medicine and Health Policy at the Dartmouth Institute and one of the original architects of the Accountable Care Organizations, or ACOs. Hi, Elliott. Welcome to the show.
Hey, Nick. It's great to be here. Thanks.
So we're seeing huge variations in care. This is not just in the US, but I think worldwide, where an individual that comes in with a set of symptoms, maybe even a diagnosis, but they're getting widely variable treatment, and even though there's variations, we're not seeing the value of all of this difference. In fact, it can be a hindrance to the positive outcomes. What's going on?
Well, there are many things going on, and it's important to look at a couple of different kinds of variations. So if you think about the evidence-based stuff we get, like percutaneous coronary intervention, for angina, the variations in your likelihood of getting that for a heart attack are actually quite small because the evidence is very, very strong that your life will be saved if you're in the middle of an acute myocardial infarction and someone blows a balloon up and pushes that little clot out of the way. The evidence for stable angina, when you've got a fixed obstruction, is much weaker. And what you see is tremendous variations in the likelihood of you getting that particular intervention. And that's part because the science is weak about who really benefits, although the science has gotten a lot better. And it's pretty clear that people with stable angina don't actually benefit much from early intervention if they're not having acute coronary symptoms. So it's really important to understand the underlying causes of variation in clinical decision making. One is insufficient evidence, and that's pervasive in medicine. There's so many things being developed that have not been adequately evaluated. The last systematic review that I saw looked at 3,000 treatments. Half of them had evidence of effectiveness. So these are things that we believe are going to be our clinicians believe, but we don't have the evidence to support it. The second thing is that we as clinicians, as practicing physicians, often fail to take into account how patients differ in their preferences for certain outcomes. So while we are the expert in knowing what the outcomes should be, equally important, patients are the experts in what the different outcomes mean to them. So for breast cancer early treatment, do women want to preserve their breast? Some women feel that's absolutely essential, whereas others feel their breast has betrayed them. That decision should be theirs, not the clinician's, not the physician who's trying to treat them, because the outcome differences are trivial between those, except in the patient's experience of those clinical outcomes. There's another kind of category of spending, a category of services, which is how often do you go to see the doctor? How much time do you spend in the hospital? Those are decisions we're taught nothing about in medical school. And when you look across US regions, and this is what we did in the early 90s, what we found is that there's some regions, there's basically a twofold difference in per capita spending. Twice as much money spent for Medicare beneficiaries in high spending regions compared to low spending regions. Group them into fifths, the top fifth, the bottom fifth, it's a 60% difference. The explanation is that those people are spending much more time in the hospital, 60% more patient days in the hospital, and seeing almost twice as many specialists per person in the high spending regions. What our early work revealed, and quite convincingly, was that the people in the high spending regions were not getting any benefit from that additional treatment. Quality was no better, health outcomes were no better, patient experience was no better, but they were spending 60% of their more time seeing docs. What that did was sort of crack a widely held assumption that more medical care is always better, and revealed that, well, we could, there's about 30% of healthcare spending that's being wasted on unnecessary stuff. People are getting the same number of stents in both places. We're all practicing to the extent of our ability, but they're just spending more time getting unnecessary care. And that led to trips to Washington to explain it to Republicans and Democrats. Peter Orszag started walking around with our maps, talking to Congress. And that's what led us to start thinking about, so how can we reduce the waste in American healthcare so that we can provide great medical care to everybody, which I'm totally convinced we should be able to do.
Well, we certainly ought to be able to do it, given how much we spend comparatively to all these other places that are delivering, let's be clear, I think for the most part, better care in many instances, not across the board, but certainly in a lot of instances. A couple of points around those, groupings that you saw. Did you see any geographic breakdown? Because there's a part of me that just intuitively would say, well, if you're seeing more care, you're closer to large healthcare facilities. Is there a relationship there, or is it completely random across the geography?
It's not completely random. But there are rural areas that get a whole lot more and rural areas that don't. You can compare San Francisco and Sacramento, both pretty urban places, with Los Angeles, twofold differences. You can compare Minneapolis with Florida, twofold differences. Uwe Reinhardt always used to quip, how is it possible that the best medical care in the world costs twice as much as the best medical care in the world? Well, as you were saying, we have good care, but it costs twice as much in some regions. So that didn't explain it. And we've looked across academic medical centers, twofold differences between academic medicals, the patient's experience and cost of care in high spending academic medical centers compared to low spending academic medical centers.
Okay, so my attempt at the obvious explanation fails immediately. Did you find any underlying elements that were able to drive you towards potential solutions? What was driving these differences? Because certainly as a patient, I want to be in the lower treatment if I'm getting the same outcomes, I think.
So the major factors are really different amounts of capacity. How many hospital beds per capita do you have? You know perfectly well, Nick, that hospitals, the way they're paid now under fee for service, they have to keep their beds full. And we train financial leaders of hospitals in how to generate revenue, because they and the way you do that is by having your physicians fully occupied and your beds fully full. And what we see is that the combination of the numbers of physicians per capita, and beds per capita explains more than half of the variation in U.S. in spending across regions. So, if you're in Los Angeles, still one of the highest, most expensive places in the country, you're like 3 times as likely to have 10 or more physicians involved in your care. And if you think it's fun going to talk to multiple specialists to follow up on every little abnormality someone finds, most patients don't appreciate that extra time, although they think they're getting great care still. And so the benefits, it's hidden from view because we can't observe it without measuring it. And the opportunities to do better are just pervasive.
So tremendous scope, but obviously some significant challenges, and that variability driven by some basic economics that if I have capacity, I need to fill it under the current model. As you thought about this and the way in which we address it, some of this must come back to standards of care, perhaps care pathways, which, we've heard about, talked about, but, I repeatedly hear, no, I must have my clinical freedom. How do we navigate through this?
Well, evidence helps. Clinical pathways can help where the evidence is clear. Otherwise, it's really got to be about changing the incentives so that physicians and the systems that support them and support patients can try to improve the outcomes of care creatively, so that they can deliver the best possible care in the least expensive way. And that's when you look at the way, some places, Mass General, for instance, when it shifted most of its payment models to, alternative payment models, which we may talk about some more, things like accountable care organizations. They started to say, how can we invent better ways of caring for our patients with chronic illness? And the old way was under fee for service. Let's have, a patient come see a specialist for every single thing they need. And, there was a classic patient that was described to me who, had cystic fibrosis, had a lung transplant, and she was experiencing 200 contacts with the healthcare system, most of them in person in a given year. With a good chronic care manager, a nurse who could help her navigate and do the talking with the specialists, she went to, fewer than 10 contacts a year or something like that. So she was given her life back. So you can deliver great care in innovative ways that make sure that the right treatments are being given, but without the burden that's imposed by this relentless fee-for-service healthcare system that has us on the treadmill of keeping the offices full, not allowing us to invest in things that aren't paid for under fee-for-service, like a chronic disease, a nurse manager to help you manage your chronic conditions. So we can, through redesign, rather than rationing, we can radically transform healthcare so that physicians still have flexibility in their decision-making. Where evidence is there, they should be using it. But most of the decisions docs make are made with some degree of uncertainty and need for judgment, to use their judgment to say what's best for the patient. And another visit or another test or a treatment that's unproven isn't necessarily the best way to improve outcomes for those patients.
So as you're talking, I'm thinking a lot about the sort of gatekeeper model that exists in the NHS system in the UK. A lot of the care is, I'm going to use the term control, but I don't think it's full control, but there's certainly some aspects of gatekeeping. And there was a paper written many years ago that talked about the value of that, because you can't overwhelm the specialist by having everybody show up with minor ailments and you need somebody to sort of limit or at least filter what runs up to the specialists that are the most highly paid and delivering, the most appropriate care, let's hope. How do we reconcile that in the United States, where there seems this just insistence on, I must have direct access. I have a problem with X in my body. I'm going to go directly to that specialist. Is there a way of reconciling that so that people don't feel that they're being inhibited or limited?
Well, it's obviously a difficult dance. At the same time, team-based care, where a primary care clinician, if there's any uncertainty, can reach out to the specialist and get a phone consult immediately, can be incredibly effective. Much more parsimonious, both of the specialist's time, because most of the time they'll be able to say, sounds great, I don't need to see them, here's what you do. Or say, that sounds uncertain. And I had one of my students in our program on population health described, banging his knee, twisting his knee, and the routine in some specialty-oriented systems would have been MRI before I see you, and I can't see you for 3 weeks. And this was it. So in Kaiser Permanente, where he was getting care, which most think of as it's a capitated system, where many see it as a constrained, like the UK. Well, the orthopedic surgeon was on the phone within 20 minutes of his seeing the primary care doc, came down to see the patient, did an actually very careful physical exam, was able to say exactly what the cause of the injury was, and prescribed the treatment that did not require an MRI, required, some physical therapy, and the guy was better in 3 weeks. So the clinical expertise, we need specialist expertise. The question is, how do you get it where it needs to be? And, with telehealth, with phone consults, and with payment models that don't require everyone to touch the patient in order to and send a bill, primary care systems are encouraged to have clinician experts, so they make sure the right person gets to see the right treatment gets prescribed to the patient.
So I actually really like that, because to me I'm going to say telehealth 4.0. I'm just randomly picking 4 at this point, but sometime further downstream where we are now, which was telehealth is great, everybody wants access, and then there's a little bit of a pullback. But what you're describing is that almost instant, or at least close to instant access for the primary care provider, or the initial consultation that brings in the specialist. It makes them more available and is optimizing from time, and allows for better outcomes with that contribution. So I think there's a pathway there, but I immediately come back to the payment models and the incentives that you measured and or mentioned at the outset. And you have a long and storied history in creating ACOs. You central to that model, which, despite being introduced and implemented back almost 10 years ago, if not 10 years, hasn't delivered on the promise that I think we expected. Is there another piece to this puzzle that needs to be included?
Yeah, I think first, you're right. We haven't, although when we did the initial modeling that persuaded the Congressional Budget Office to approve it, it estimated that they estimated we get about the amount of savings from ACOs we have, because it's partial pickup, right? It's only being picked up by a few places. 30 or so % of Americans, or maybe it's 30 million, actually it's 30 million Americans are covered under the model. And what's required for that model to succeed is you have to have all of the payments to the provider group under this new payment model. Right now it's a mixed model. Under the mixed model, I'll see my ACO patients, and actually I'll try not to see my ACO patients. We'll try to manage their care with nurses and whatever. We'll have them, and we'll reduce the cost of care for those patients and probably improve outcomes for the subset of our patients. But for the other patients who are paid fee for service, well, we're going to still put them in the hospital. We're going to raise costs. We're going to do all all of the traditional ways we practice under fee-for-service medicine. So it's actually more expensive. Costs go up. You've saved a little money, but rewarded them for saving money on your ACO patients. And meanwhile, you've increased costs because you've freed up some capacity in the hospital to take care of your non-ACO fee-for-service patients. So the way the model will work, and I'm still totally optimistic. I think we're starting to, you listen to people, ACOs or alternative payment models, value-based payment. It's still the coming wave. It's further off, it's a long way offshore, but everyone agrees that it's where we have to go. Docs and hospitals aren't very well prepared for it. They're scared of it. It requires change, especially if you're in two models. But when you move to a model that's fully capitated, that's when you can do what I just described. Team-based models, ready access to telehealth or asynchronous care like email or text messages with your clinician, reducing the burden of care on patients. And if you can take care of patients more efficiently in primary care, now you can afford to make specialist care through innovative methods much more accessible. And so I think the evidence, where you look at what's happened at KP, Kaiser Permanente, compared to fee-for-service quality generally in California, KP is just hand and fist above everybody else in terms of its ability to take great care of people with diabetes, heart failure. There may be some places where it's access to the tertiary care, quaternary care seems more difficult or is more difficult. But I'll tell you, when my daughter, had a newborn with a question of cytomegalovirus infection and brain damage, she was seeing one of the country's leading expert on that within 24 hours of the birth.
So I think great potential, not it's not evenly distributed. It seems to be just a little bit West Coast centric. But potential to expand, I think opportunity to drive out waste, and deliver a better product for the money that we're paying. What would you leave us with in terms of the next steps?
Well, I think the important next steps are to get all payers, commercial payers, Medicaid, Medicare, aligned around a common model for ACO work, whether it's signing up, people have to choose once a year. That would probably be ideal. It's freedom of choice. Choose a different system if you want each year, but all patients in the system should be paid under this, prospective capitated payment, with good performance measures that make sure they're not stinting on care, which are perfectly available now. So I think if we move toward a unified approach to payment, and systems decided that and were willing to do it or forced to do it, we could accelerate the improvement in healthcare rather dramatically.
Elliott, thanks for joining me today.
Hey, Nick, this was fun. Good luck. Take care.
We need alignment on payment models for everyone in the business of healthcare. This is not about removing choice, imposing a single payer system, or limiting people's access to care. This is about delivering the right care to the people everywhere, not just those fortunate to be in an area that has the right match between available healthcare and patient demand, but to everyone. We should all be united in removing all the waste from the system, both at a system and clinical level, but also at a patient level. Your better pill to swallow is to acknowledge that each intervention and treatment comes with its own set of risks and rewards. Adjust each decision based on the risk-reward equation for the individual, accepting that more is not necessarily better. And this is especially true for healthcare. Thanks for joining me, your host, Dr. Nick, on this week's edition of Healthcare Upside Down. Until next week, keep solving the business of healthcare as if your life depended on it, as one day soon, it will.
That's all the time we have for today. You can find all of our episodes on your favorite listening platform by searching for Healthcare Now Radio. Also, check out our blog at ecgmc.com/HUD for summaries and commentary from each episode. Follow our show's social hashtag HC Upside Down. And join us each week as we work to solve the business of healthcare for everyone.